What are your indications for deciding that you are going to do an intervention or a bypass? Is it, I mean, does it vary? Because you have people that are asymptomatic, and asymptomatic could mean even just like numbness, right? They're like, oh, I don't feel the traditional intermittent claudication. Then you have the intermittent claudicants. Then you have the lifestyle limiting claudication. And then ultimately, then you have the rest pain and the wounds that won't heal. And there are doctors that say, I am not going to treat until I see that wound, until your toe is gangrenous, we're not going to touch it.
Yeah. Okay. So I guess, first of all, there has to be a lot that should be said about non-surgical conservative treatment. If someone is asymptomatic, then absolutely we talk about stopping smoking, we talk about dietary modification, we talk about exercise, we talk about counting steps per day. I know, Kim, you've got that great little booklet that I've got here somewhere that I've been giving out to patients that explains to them why do you have PAD and what are you going to do to stop it from getting worse, and the cookbook as well. So they're things that we give out. If someone, so generally speaking, if someone has claudication and it only occurs once a week, and it maybe only occurs if they're walking more than 100 meters, I will try to manage that conservatively, and not forever, but we'll try to manage it conservatively. So, I'll say to the patient, all right, let's get a pedometer, maybe like a Fitbit. Let's see how many steps you're doing per day. Maybe instead of watching TV for 3 hours, why don't you go for a walk around the block, or wake up in the morning, go for a walk, really try and manage things without intervention. Once we get to under 100 meters, I generally will find patients will tell me, I can't do anything without getting pain, right? So I go to the supermarket, I have to stop in the aisle because that's 100 meters. Or, I get to the lift and then I have to stop there and rest. And it really becomes lifestyle limiting. Now, when someone's lifestyle is limited by pain and there is an easy target for treatment, I will treat it. I will obviously warn patients that there can be this sort of revolving door, but the way to stop going through that revolving door is not to smoke and is to walk a shitload. Excuse my French, but really, really to walk after having your intervention done, because you've got to build the collaterals. You've got to push a lot of shear stress through that stent to keep it open, or wherever you've ballooned it or done your atherectomy, whatever the treatment is. You want it to heal. You want it to positively remodel, and exercise is a really good way for that to happen. And of course, once someone's got CLI, critical limb ischemia, there is no role for conservative treatment. I think that is a limb-threatening and life-threatening situation. And so they will generally need revascularization of the limb, number one. They will need very advanced care of their medical comorbidities. So, referral to an endocrinologist, cardiologist, et cetera, antiplatelet treatment. And really, I worry a lot about CLI patients because a lot of them don't make it to the 12-month period after I first meet them. So, I don't see that. There's very few that I manage conservatively in that group.